Hi everyone, thank you for waiting. My name is George and thank you for joining us today. I'm one of the board members at SUPTA. This week we're focusing on neurosurgery and we're very excited to have you all join us today. So today I'm joined by Zach, who's going to guide you through back pain. Zach is a second year medical student from the University of Edinburgh. So to make these sessions as engaging as possible, we're going to be releasing polls throughout. These are completely anonymous, so we encourage you to participate with them. If you have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we'll share the feedback form with you. If you complete this, then you'll get a certificate of attendance and exclusive discount codes for Teach Me Surgery and Pass the MRCS. Additionally, this session is being recorded and the recording and the slides will be shared to our medal page a couple of hours after the session, so be sure to keep an eye out for that. We're also excited to share that we have an exclusive question bank and other resources that you'll be able to use on our learning portal. So please check out our website, which is SUPTA UK, to access them. If you create a free membership account with us, you'll automatically receive a discount code for 10% off the Geeky Medics Anatomy flashcards, surgery flashcards, and the knowledge bundle. We also have an exciting opportunity for all our attendees. So 2 lucky people will win access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. That'll be for free. So to enter, please simply complete the Google form at the end of the session, enter the unique code that we provide. The more sessions you attend, the higher your chances are of winning. So please be sure to stay till the end of today's session and attend as many of our other sessions as you can as well. We'd also just like to thank our partners, the Royal College of Surgeons of England, Geeky Medics, the MDU, More Than Skin Deep, Medall, Teach Me Surgery, and Pass the MRCS. And a final couple of shout outs. So please watch our social media pages. We're going to be releasing our conference very soon. This will be open to everyone, but is specifically aimed at medical students, and will be a national conference, which we hope that people will be able to present at. And we will be opening abstract submissions soon for that as well. So please do watch out for that. And also we do have the Preparation for Life as an F1 series, which will also be coming out soon. So again, please watch our socials for that. And without further ado, I will hand over to Zach. Thank you.
Thank you for that kind introduction. Just checking, can you hear me and see my slides?
Yes, we can.
Okay, cool. Okay, so welcome everyone. Today we're going to explore one of the most common complaints we'll see in medicine, back pain. We'll try and do a whistle-stop tour of the different types of anatomy, pathology, and some red flags that might indicate a more serious underlying condition. So, as my colleague said, thank you to our partners for making this possible. Sounds like there's a lot of good prizes up for grabs. Here, just some of the learning objectives. I won't list them, but you can see kind of the main things that we're going to cover here and here. Well, I'll just try and keep it a brief whistle-stop tour of the different anatomy and pathology. So let's start with the basics, the vertebral column. The structure is central to human posture, movement, and protection of the spinal cord. It usually will consist of 33 vertebrae, but this does vary depending on the individual, as I'll go on to talk about in a bit. So 7 cervical, 12 thoracic, 5 lumbar, 5 sacrum. What's interesting about the sacrum is during development, the bones actually develop individually, but then later on during the development process, they become fused, and it's similar with the coccyx. But there's actually some variation in the number of bones in the coccyx particularly, which is why that number can change depending on the individual. So those are just the main function, support, movement, and protection, as you mentioned before. The vertebrae, they also vary in shape and function across the different regions, as we'll get into. So the specialized vertebrae, the first 2 cervical vertebrae, they're uniquely adapted for head movement. The first one, C1, or the atlas, it supports the skull and has no vertebral body. A good way to remember that this is the atlas is Atlas is like somebody who's holding up the earth, and the atlas in anatomy terms is the bone that is holding up your head. Then there's C2, the axis. It's distinguished by the dens or odontoid process. They're both the same thing, but depending on the where you read it, might use different names. And it serves as a pivot. There are major joints formed here. The atlanto-occipital joint, which allows for the nodding yes movement, and the atlanto-axial joint, which allows for rotational movement to the no movement. Understanding this anatomy is crucial, especially in trauma scenarios where C1 and C2 fractures can have catastrophic consequences. So in terms of the actual different vertebrae themselves in general, the vertebrae, they vary in shape and function across the different regions. The cervical vertebrae, they allow for greater flexibility and support of the head. The thoracic region anchors the ribs and limits movement to protect thoracic organs, while the lumbar region bears the body's weight. Clinically, understanding the location and nature of back pain can often be linked with the specific vertebral regions. This is why it's so important to understand the fundamentals. In terms of the movements, one of the key functions we talked about there, what was the movement? This movement, it depends on several anatomical factors. As we can see in these diagrams, there's loads of different ways that you can move your vertebral column. Some things that will affect this are the disc shape. So invertible discs, they act as shock absorbers and allows a slight movement. The facet joint orientation, these determine the type of movement. So for example, the cervical facets allow for more rotation. And also the ligaments and muscles, which provide some stability and can help guide movement. Overall, the cervical region allows for the most motion, especially rotation, as you can see in those diagrams there. The thoracic spine is more rigid due to those rib attachments that we were talking about, and the lumbar region allows flexion and extension, but limited rotation. So just to summarize briefly, there's 33 vertebrae consisting of those different groups. C1 and C2 enable head movement. Facet joint orientation, the discs and the muscles, they can influence movement. And knowing this is very important in helping to localize back pain and pathology. So here's one of the questions. I believe this will be one of the ones in the poll. So you can either message in the poll or type in the chat. Which of the following structures is responsible for the primary rotational movement of the head? A, B, C, or D? And I'll just give you a minute to... Okay. It is B. Okay, so now that we've talked about the anatomy, it's time to talk about some of the pathology. So shifting into pathology, the back pain has a wide range of different causes. As you talked about before, it's probably one of the most common presentations that you will see. So there are things like mechanical issues, like strain to the muscles, degeneration of discs, or facet joint arthritis. There's nerve compression syndromes like sciatica, for example. Inflammatory conditions like ankylosing spondylitis. And there can also be quite serious conditions like malignancy, infection, or Cauda-Equina syndrome. So we'll be starting with AS, or ankylosing spondylitis. So AS is a chronic inflammatory disease of the spine and sacroiliac joints. Some of the key points are highlighted in this nice infographic, and I think this is quite good for revision of this infographic. It summarizes it quite well. The onset of AS is usually in teens to 30s, and it's more common in men. It's associated with the HLA-B27 gene. Now, the relationship is actually quite interesting. So of the population that have AS, the majority of them will have this HLA-B27 gene. But of the general population who have the HLA-B27 gene, only a small minority will have AS. So, for example, I actually have the HLA-B27 gene, but well, at least not as of yet, I haven't been diagnosed with AS. So even though you have the gene, it doesn't necessarily mean that you will get the condition. But having said that, within the population of people affected by AS, HLA-B27 is very common. Some of the actual symptoms and presentations that you will get is a morning stiffness that will improve with activity. So with any of the your joints, if they're not moving for a prolonged period of time, either you're sleeping, hence the morning stiffness, or sat down for a long period of time, long haul flights, this will be improved with activity. And what's interesting about AS is it's a insidious condition, meaning that over time it gets worse and worse, kind of like a fire building up. And over time, it can lead to spinal fusion or bamboo spine. So here's sacroiliac joint. This is one of the main joints that is affected in AS. And you can just see there some of the useful diagrams to illustrate sacroiliitis, which is a potential complication of AS. And you can see kind of the different grades. We won't go into the specific grades in the sake of time today, but there's a lot of really good scans on UpToDate, and this is 2 examples of such scans. So treatment, so how do we treat them? As I mentioned, it is an insidious condition, meaning that it's very chronic and it builds up over time. To summarize, early diagnosis and treatment with NSAIDs and biologics, they can prevent complications as seen here. But the key is early diagnosis and treatment with drugs and some sort of physiotherapy as well. And the reason why is it being insidious condition means that if it goes for a very long period of time without being noticed, without being treated, then the conditions like inflammation or the bamboo spine that I mentioned, they will be so bad that it cannot be reversed. So the main thing that you can do is preventative measures to slow down the progression of the condition. There's no current known treatment to actually stop it. It's all about prevention and managing symptoms. Okay, so the next one, lumbar radiculopathy. So in general, this can be put under the umbrella term of nerve root compression. So nerve root compression or radiculopathy, it happens when the spinal nerve is compressed, and typically this is from a herniated disc. So we can see here the lumbar vertebrae that we saw before in the previous slides. Hence, again, linking to the fact that anatomy is very important in understanding pathology like this. Here's an example of where the nerve foramina is going to come out, and that is where if you have a herniated disc, it can lead to some issues with compression there. Some of the symptoms of this, some of the common symptoms you might get is radiating pain in a dermatomal pattern. We will talk about dermatomes and myotomes shortly. There's things like numbness or tingling, and there's also weakness in specific muscle groups. So for example, if we have a compression, this is a lumbar example here, compression of a L5, it can cause pain down the lateral leg and weakness in toe extension. And one of the ways clinically that this is important is if a patient is presenting with specific symptoms, you can often link these symptoms to specific regions of the specific nerve foramina. So it's very important to know this well, and we'll go over this in a bit. Okay, so just to summarize the main pathology of the vertebral column, there's AS, which you mentioned, chronic inflammatory condition, usually presents in young men, has some sacroiliac joint involvement, and that bamboo spine is a very common feature. So mechanical back pain, well, we didn't really go over that in that much detail, but that's just usually linked to heavy lifting or any sort of strain or trauma. and it will have the diagnostic process is similar to the other conditions that you mentioned. Sciatica lumbar radiculopathy, we just mentioned that, and the most common culprit is disc herniation. And in terms of what anatomy is important, is understanding the nerve roots where they supply, and also understanding a bit about the vertebrae themselves, which we discussed. Speaking of knowing the anatomy of vertebrae, that is very much the case in osteoarthritis as well, which is also chronic degenerative, similar to AS. And this can lead to changes in those facet joints and discs that we talked about earlier. And as a result, that can lead to quite a lot of negative symptoms. In terms of when you're going through the diagnostic process and the management process, similarly, knowing your anatomy is really important. And that's something that I really like about the spine and back pain in general, is it really pays well if you know your anatomy well. And it's something that makes it very interesting to revise and study, I think. And finally, spinal cord compression. We'll talk about this a bit more in depth with the spinal cord pathology, which we'll discuss in a bit. But most common culprit is disc herniation, similar to sciatica, but also tumors or trauma. Okay, so here's another question. This should be in the polls, or this should be a similar one in the polls. Which of the following is not a feature of AS? A, B, C, or D. I'll let you either type it in the chat, or you can answer the poll, and I'll give you a second to do that, and you can move on. Okay. All right. So it's D. Okay, move on. Okay. So we've done a lot on the vertebral column. Now we'll do a bit on the spinal cord. And you see that the spinal cord, so it's a start to C1 after the foramen magnum, and it terminates at L1, L2. There are different segments. The cervical segment, which has 8 pairs of spinal nerves, thoracic segment with 12 pairs, lumbar with 5 pairs, sacral with 5 pairs, and coccygeal with 1 pair. So overall, in total, there's 31 pairs of spinal nerves. And these spinal nerves are extremely important in understanding back pain when it comes to diagnosis in clinical cases, as we've stressed earlier on today. And the different ways you can remember it, and there's lots of different mnemonics you can use as well that can be useful. The thing that's interesting, and some people might know this, some people might not, but a common question that people get when they're studying this for the first time is how come in the cervical section there is 8 and not 7? The simple explanation is in the cervical segment, it's the only segment where the spinal nerves are moving above their vertebrae. And from the thoracic down, the nerves will be moving from below their vertebrae. And this is one of the reasons why we have that kind of interesting difference that can confuse some people sometimes. So we'll discuss this a little bit later, but the end of the spinal cord, L1 and L2, is the conus medullaris. And then there's the spinal nerves from L2 to coccygeal, and then the cauda equina, which we will go into depth in a bit. So here, this is a transverse section of the spinal cord as you go down. That butterfly-shaped region, that is a gray matter, and the outer region is white matter. It is quite confusing that in the most common stains that they use, the white matter will appear gray, and the gray matter will appear white. But there is a good way to remember which way around it is. So the gray matter, the reason it's gray is it contains the neuronal cell bodies, whereas the white matter, it will contain the myelinated axons, which are very fatty, and as a result of that fat, it appears white in appearance. So hence the outer bit will be in the spinal cord, will be white, as all those signals are being sent out to the limbs, the legs, different parts of the body, and those neuronal cell bodies, they will be in that butterfly region in the center, being gray matter. In general, what you'll notice as gray matter will increase in the lumbar and cervical region. So you see there's a bulge in the lumbar and cervical regions, and that's just because of your limbs. But in general, as you go up the spinal cord, the ratio of white matter to gray matter will change in relation to the difference in function, and also the fact that as you go up, there'll be more spinal nerves being added, and the same on the way down. And I think that's an important concept to get your head around. I haven't included a diagram of that here, but in hindsight, it is very useful to try and understand why there's a difference in distribution in white and gray matter as you go up and down. But an easy one to remember is it bulges at the cervical and lumbar regions. The cervical, you've got the upper limbs; lumbar, you've got the lower limbs. Okay, so here, this is the end part that we were talking about a bit earlier. There's a conus medullaris, cauda equina, and that final kind of strand is the filum terminale. Those are some interesting little pictures that I've put next to them, and I found that quite useful to try and remember the names and understand what they kind of look like. The conus medullaris literally looks like a cone. Cauda equina, it kind of looks like a horse's tail, which is where the name actually derives from. And the filum terminale, it kind of connects to that the bottom part of your cavity. Okay, so the spinal cord, in terms of the supplies, it has arterial supplies from the anterior and posterior spinal arteries, and these arise as the vertebral arteries. We won't go to the blood supply too much, as it's not really that linked to anything we talk about today, but it is good to know. So here, more specifically, we have the transverse section, and we'll go a bit more in depth. So in the spinal cord, there is the dorsal horn or the posterior horn, and this is at the back of the spinal cord, and this contains the sensory neurons that will receive input from afferent or sensory fibers, as indicated here. And these things, it will process things like touch, pain, temperature, and proprioception. And they're associated with the spinal thalamic and dorsal column medial lemniscus pathways. Then there's the ventral or anterior horn, which is located in the front of the spinal cord, and it contains the motor neurons that send efferent signals to muscles. So you can see these arrows kind of indicate if they're afferent or afferent. So these will be responsible for a voluntary movement via the cortical spinal tract, and are more prominent in regions controlling the limbs, as you mentioned, so the cervical and lumbar regions. Then on here, you can see the lateral horn. And what's interesting in the lateral horn is it's only in the thoracic and upper lumbar region, so T1 to L2. And what they do is they're preganglionic motor neurons of the sympathetic nervous system. And they're located in the intermediate zone between the dorsal and the ventral horns. And they contain autonomic neurons of the sympathetic nervous system. So they'll be important for visceral motor control. So things like regulating the heart rate and digestion. So in summary, the dorsal horn, they're sensory. The ventral horn is motor, and the lateral horn, which you'll only see in the thoracic or upper lumbar regions, is autonomic. Okay. Also here, it might be important just to look at the way that they go. So they go here, and then they leave as a mixed spinal nerve. Okay. Just to conclude, I know there's a lot of information, but the spinal cord, it runs from the foramen magnum at the top to L1, L2. You have 31 pairs of spinal nerves, and the breakdown of them is indicated there. White matter is the myelated nerve tracts, which are located on the outside, and gray matter is the cell bodies. In the stains, like the one that we just saw in the previous slide, this one, it can be a bit confusing because I swapped the other way around. But by focusing on those key differences in function and what they contain, that makes it a lot easier, I think, to visualize. So it ends at the conus medullaris and continues as the cauda equina, as we saw in those anatomical diagrams. And blood supply in spinal arteries. We haven't gone into too much detail of the blood supply for this specific section, but it is still important to know. Okay, so here is a question. You might have a similar one in your poll, but if not, you can also just type it in the chat. So I'll just give you a second to do that. Okay, so it's B. Okay, so now the pathology. So lumbar radiculopathy. We mentioned this briefly before, and as we said, the most common culprit is disc herniation, and it can also be to things like spondylitis due to degenerative conditions like degenerative osteoarthritis. Presentation, it will vary depending on which nerve root is involved. As we have stressed throughout this talk, it's very important to know the different nerves and where they supply, what their functions are. As this is the anatomy is very important in actually clinically doing surgeries and management diagnosis of these patients. So each nerve root, they provide a sensation to a specific part of the skin, and this is called a dermatome. And they also provide certain innervation to certain muscles, which is known as your myotome. So muscle, myotome, that's how I remember it, and dermatome is the other one. So some examples. I mean, I know we have L5 mentioned there just because it's the most common type of radiculopathy, but there's also so the L5. You usually see some symptoms on the lateral leg, top of the foot, and toe extension. But other examples, S1, for example, if you have the S1 dermatome, that's responsible for the lateral foot, and the S1 myotome is responsible for plantar flexion. So just two examples, but it's good to know them for all of them. But due to time constraints today, we won't go into all of them in depth. But those are just two of kind of the most common ones, L5 definitely being the most common. So dermatomes, you can kind of see there. I'm sure you've seen this map either in one of your lectures or in a GP. A lot of the time, they will have a similar map to this, or even a model like this where they're sprawled out and you can see the different dermatomes. And just to reiterate again, that's the area of skin supplied by a spinal nerve. There's also the myotomes, which is a muscle group controlled by a spinal nerve. And those are just some common examples there. So L5, you mentioned toe extension, and S1, plantar flexion. Okay, so we've kind of done a whistle-stop tour of a lot of the different kind of conditions there. But I think something that's very important in back pain is we're talking about the spine. And the spine, is very important. And if things go wrong, they can go very wrong. So it's very important to be able to recognize any red flag symptoms. So this is a list of a lot of them, but the ones that would stand out to me and are very easy to see either in an exam or, if you actually face the patient is there anything with their bladder, so any urinary retention or incontinence, fecal incontinence, or what we call saddle anesthesia, where there's some numbness around the anus. But there are some other things as well, like if they might have cancer, or if there's some sort of severe motor deficit or an infection. These are all things that you should be thinking, hold up, we need to do some more investigation. We need to check if we need some further management here. So this is just a general statement, because I know we didn't really go too much into detail with mechanical back pain or radiculopathy in terms of the actual treatment. But as I mentioned before, the key things will be exercise, keeping active, and physiotherapy. And you'll find that a lot of these back pain things, physiotherapy, exercise, is very important in maintaining health and also recovery. So maintaining health in more chronic conditions like AS, but also important in recovery in certain symptoms as well. So cauda equina syndrome, the red flag symptoms we talked about before with the shadow anesthesia, these things, that is, a lot of those are very commonly linked with cauda equina syndrome. And cauda equina, as you mentioned, if you forget what it is, just think about the horse's tail, which is what it is derived from. If there's any issues here, a lot of bad things can happen. So there are things like protrusion that can cause a central disc protrusion, malignancy. So remember thinking about if the patient might have a suspected cancer diagnosis or is at risk. Um, and the back pain, is usually first followed by progressive neurological signs. So things like, as you mentioned, problems with the urinary retention, lower limb weakness, or anything sensory too. And it is a medical emergency, so it's very important. I'm sure this has been stressed to you all many times. Cauda equina syndrome is very, very important. If you see any symptoms of cauda equina, you have an urgent referral and you do a scan. And neurosurgical intervention, it may be required as well. To summarize, I know there's a lot of different things we went through, but I am aware that I apologize for starting a bit later. I had a clash with my work today, so I didn't want to keep you for too long. So I've tried to really condense the slide I had before into the key points that are very important for you to take away, and hoping that this will be useful for you in your revision for your upcoming exams, or if you're older, in helping you with your placements later on during your FY years. So lumbar radiculopathy or sciatica, the L5 is the most common area affected, and it will cause issues with the foot, dorsiflexion, and a toe extension. But although that's the most common, we've also mentioned S1 and L4. The symptoms, they depend on the dermatomes and myotomes. It's really important to get really familiar with just them in general, although do have back in your mind L5, S1, L4, those are the most common ones that you'll see. But in general, just knowing all of them to some extent is very useful in not only your exams, but also when you're actually seeing patients as well. And again, I really, really love the fact that with spinal pathologies of back pain, anatomy is so crucial to understanding it. I think that's really, for anyone who's a real anatomy nerd like myself, that it's really nice how those two things are very clearly are linked with each other. Okay, so red flag symptoms are very important. So as you mentioned, I'm going to sound like a broken record here. Saddle anesthesia, anything to do with urinary or fecal retention, or if there might be some infection or malignancy cause, those are very important things for you to flag. And a very big red flag condition that you should be thinking about, as we stressed at the end there, is cauda equina syndrome, which is our last point. So things like other things you mentioned, there's also bilateral leg weakness, perineal numbness, and what you would do is you would have an urgent scan and you would have a possible surgical decompression too. Okay, so here's a question: which of the following symptoms suggest cauda equina syndrome? So it's a very important thing to be able to spot, not only for your exams but also in real life as well. So I'll give you a second to answer that, and either just type it in the chat or there'll be a poll up that you can answer a similar question on. Okay, so it's this one. Okay, so overall summary, I know that was very fast, but as I was saying, I want to be very considerate of your time. Thank you. I know it's usually starts at 6:30. Thank you for people who have stayed on for the later session. I apologize, it was a clash with my work, but I hope that was useful in somewhat in giving you some good information and pointers on what are the key areas in back pain you should be looking at, not only in terms of the conditions and potential treatments, but also the anatomy. And the anatomy is so important. And as I say, I love that about back pain. It makes it so fun to study, but there's so much really interesting anatomy linked with that. So back pain is very, very common. But for the majority of patients, having that active lifestyle that we talked about is very important, not only for more chronic conditions like AS, where it's a chronic condition where you can help use that to try and slow it down, but also in more acute conditions as well after the fact with recovery. So really understand your anatomy, understand your nerve roots, and really be aware of those red flag symptoms. Those are the key things you should be taking away for today. Okay, that's me finished. Thank you very much for your time, and thank you, SUPTA, for making this possible. I hope that was useful for your revision. But yeah, that's me done. Right? I hope you all have a nice evening. Thank you.
Thank you very much, Zach. I hope you all really enjoyed that. So the feedback form is now available in the chat, so please feel free to have a look. Don't forget to fill it out to receive your certificates and your discount codes for the Teach Me Surgery and pass the MRCS. Also be sure to complete the Google form for a chance to win access to the Geeky Medics flashcards and the OSCE stations. Again, the link is in the chat for this. So we'd love for you to join us again in the future. Please make sure that you follow us on social media platforms. The links are available in the chat, and you will receive updates about the upcoming sessions via these platforms. Obviously, I know that Medall is starting to close for societies like ours, so please follow us, and we are moving to Career Book. So that is another resource that you can have a look at, and please make sure to follow us on there as well. We will also be posting SBAs on our socials for additional practice, so keep an eye out for those, and don't forget to visit the website where you'll find the resource bank with the materials, not just for this session, but for all other sessions in the teaching series. Also, please don't forget to check out our Prepare for F1 teaching series and our national conference, which we will be releasing more details about via social media very, very soon. We hope you found this session valuable and engaging. Thank you once again for joining us, and we look forward to seeing you at our next session.
Thank you, everyone. Have a nice evening.
So for the Geeky Medics and Pass the MRCS discount codes, these should be included with your certificate of attendance once you've completed the feedback form, Nishant.